So
we can start it now, sir.
Okay. Well, good evening, ladies and gentlemen. I am Dr. Parashar, representing the Indian Academy of Echo. As usual, every month we are having a joint webinar with some of the important international centers of echo and societies which are eminent societies, and they are recognized well over the world. So this month we are having our webinar with Imperial College London and the Royal Brompton Hospital London, which is being represented by Professor Roxy Senior, who is the professor of cardiology and a senior consultant, and everybody knows that he is a recognized figure in the field of stress echo all over the world, not even confined to one center. And he has been involved in writing a lot of guidelines and various position papers also. So it is a privilege to have this sort of a webinar with Professor Roxy Senior. So now we'll hand over to Dr. Senior, who will introduce and then give his first talk and then followed by the others also. Thank you.
Thank you, Professor Parashar, for this very, very kind introduction. I have a great privilege in working with Indian Association of Echocardiography for many years, and I'm delighted to be part of this webinar. So today's topic is contemporary stress echo state of the art, where I will start off with a talk on newer updates in stress echocardiography. And then we've got several talks which are mainly case-based in stress echocardiography, and we'll come to those talks as we go along. So let me uh, share my slides now. Let's see. Sorry, can you see my slides?
Yeah, you can just
Okay.
enlarge it.
Yeah, I'm just trying to do that. Gosh, where is that icon gone?
Yeah, next, sir. Next one. Yeah, next one, sir.
Yeah,
Yeah.
got it. Okay. So newer updates in stress echo. We know that the premise on which stress echocardiography so far rests is on detection of abnormal wall motion during stress. And this I'm talking mainly in relation to the diagnosis of coronary artery disease. So regional wall motion abnormality is a hallmark of ischemia, which we utilize during stress echocardiography. However, we also know that we do get images like this, as you can see on the left, where we can hardly see the endocardium. But with the advent of contrast agents, echo contrast agents, we can now see the endocardium very clearly. And this is an example where we've converted this almost non-diagnostic study to a diagnostic study. This is an example of exercise stress echo. You can see on the left, you can see the endocardium very clearly. And even at rest, you can see a wall thickening abnormality right at the apex. And immediately after exercise, you can see that the LV has dilated and there is marked reduction of wall thickening in the septum. And so this patient was diagnosed to have significant proximal LAD disease. Now, this is a contemporary data which was published very recently, about 3 months ago, and I'm privileged to be a part of this. It's a large multi-center study from UK where 5,503 patients have been recruited. And you can see here that dobutamine stress echo was performed in 64%, exercise in 34%, and contrast echo was performed in nearly 80% of these patients. So in other words, almost all patients underwent contrast echocardiography for assessment of wall thickening. And the diagnostic cases, therefore was obtained in more than 98% of patients. So today, echocardiography is a technique where you can get diagnostic images in almost all patients, again, irrespective of body size, etc., etc. And now this is the data. This is now looking at outcome of these patients. And you can see the blue line on the left-hand side is a patient with a normal stress echo. And below the red line is the one with myocardial ischemia. And you can see that these lines separate very clearly. And this came out to be an independent predictor of outcome in these large 5,000 patients, having adjusted for all the other factors, covariates. But more importantly, on the right-hand side, you see this breakdown of the number of the patients having an outcome based on the number of segments. So the blue line is where there is no ischemia, meaning all segments are normal. The red line is where the patients have ischemia in only 2 segments. And the third light blue line is with 3 to 4 segments, and the purple line is more than 4 segments. So you can see how there's a stepwise increase in the combined cardiac mortality and acute myocardial infarction as the number of segments with ischemia increases. But more importantly, you will see that it's only when the segments are more than 3 segments which are ischemic that actually you get the worst outcome. But if it's only 1 or 2 segments, the outcome is bad, but not as bad as when you get 3 segments. So this gives you more a precise assessment of risk stratification. And this, as you can see, is based on a large number of patients. So today, with ultrasound contrast agents, you can really get images and diagnostic images, and which actually has an important effect on how you manage the patients. And again, when patients come in with chest pain, we do a stress echo. The stress echo is completely normal. What do we tell the patient? Now, in this study, you can see that the warranty period of having myocardial infarction or cardiac mortality over a 5-year period is less than 5% if a stress echo is completely normal without ischemia. So it does allow you to tell the patient that the prognosis is very good in your case, whatever the other issues are, but because the stress echo is completely normal, your risk of having a myocardial infarction or cardiac mortality in 5 years is like 5%, not more than 5%. And so these are patients who did not have any previous coronary disease. But if patients do have previous coronary disease, and that's the red line, the warranty period is 4 years. So again, this study, because of the large number of patients, we could say with conviction what a normal stress echo and an abnormal stress echo means. So this is really for assessment of epicardial myocardial ischemia, but we know that today the prevalence of obstructive coronary disease is only 10 to 15%. So in other words, when patients come in with chest pain, only 10 to 15% really have obstructive coronary disease. And about 50 to 70% patients have coronary microvascular disease. Those patients are undergoing coronary angiography based on risk factors, etc., where the coronary arteries are non-obstructive. About 50 to 70% patients with chest pain have got microvascular disease. So it's very important to detect ischemia both on the basis of obstructive coronary disease and on the basis of coronary microvascular disease. But we know from this the slide that I'm showing you that, as I've said, we are looking at regional wall thickening abnormality as a marker of ischemia. Is somebody speaking? No. Okay. So you can see here that the wall thickening abnormality occurs because the subendocardium, as you can see here, the subendocardium is the part that is affected and if with ischemia, and if that is affected, the wall motion abnormality occurs. So if the ischemia is not in the subendocardium, you will not see any wall thickening abnormality and you will miss ischemia. And that can occur in patients with microvascular disease, because microvascular disease affects all part of the myocardium. It may just spare the subendocardium and you may not see wall thickening abnormality. And that is a drawback of just looking at wall thickening abnormality. And furthermore, we also know that, with stress echo, when you do a low level of stress test, demand ischemia, you will see that the myocardial blood flow improves in the normal territories, but in the abnormal territories, the coronary blood flow does go up, but post stenosis, there's a pressure drop, the hydrostatic pressures in the capillaries drop, and that can cause a great problem. And to prevent that, the capillaries de-recruit to increase resistance, and that results in perfusion abnormalities. So even at low level of exercise, perfusion abnormalities occur first. And then when you continue to exercise the patient, once the demand exceeds the myocardial blood supply, then you see wall thickening abnormality. And also you see wall thickening abnormality if only more than 10% of the circumferential myocardium, subendocardium, is affected by perfusion abnormality. So, in patients with single vessel disease or moderately obstructive disease, you may not see wall thickening abnormality, but you will see perfusion abnormality. So these are the two things. And third thing is, of course, as you can see in this slide, we use exercise dobutamine, and in Italy, especially, they use vasodilator stress. The sensitivity will depend on the amount of demand that is put on the myocardium, and the highest demand put on the myocardium is exercise, and therefore you can see a sensitivity of 88% for detection of myocardial ischemia, but it drops to 82% with dobutamine and to 74% with dipyridamole. So in other words, if you do these tests, it depends on the amount of myocardial oxygen demand that you put on the myocardium that will get the sensitivity to go higher. But if you're doing dobutamine and if you're just looking at wall thickening, there chances are that you are going to miss some ischemia. And there again, perfusion does help, as I've shown you. So in other words, just looking at regional wall thickening abnormality and doing dobutamine, you may miss ischemia. You may miss mild degrees of ischemia because you require at least 10% of perfusion abnormality for ischemia to occur, and you may miss microvascular disease. So therefore, we should also be looking for myocardial perfusion, which we can do with myocardial contrast echocardiography, which has been around for some time. And this is one of the examples, as you can see. So this is looking at a patient coming in with chest pain. On the left panel is 4-chamber, 2-chamber on the right, and on the left of the left panel is rest. Similarly, on the right, on the left of the right image is rest. And on exercise, you can see the wall thickening has improved. There is good contractility everywhere. And but when you look at I need to just go back again. When you look at wall thickening here, both in the 4 and 2-chamber, you don't actually see wall thickening abnormality at all, but you may see a little bit of lag in the apex, but that is not very convincing. However, when you look at myocardial perfusion, you will clearly see that there is perfusion abnormality right at the apex. You can see there's a flash replenishment while rest of the myocardium fills very well. And therefore, this patient actually has got coronary disease, though not clearly seen by wall thickening abnormality, but you can see by perfusion abnormality. And this patient, this video for some reason is not playing, has got an occluded LAD, but very good collateral supply. So the myocardial ischemia is small, and that's why you missed it on wall thickening abnormality, but you did not miss it on perfusion assessment. And large multicenter study, as you can see below, has shown that it is more sensitive than SPECT for detection of myocardial ischemia. And now we come to another case scenario where the wall thickening is completely normal in a patient with normal coronary arteries. but the patient has got typical angina, but the wall thickening abnormality is normal. And the reason why you don't see wall thickening abnormality is because you are because there is no ischemia affecting the subendocardium. But when you look at just let's see, yeah, when you look at perfusion, see what happens. So you see this flash replenishment. You can see the perfusion, the myocardium is perfusing very, very slowly. You see it again, very slowly. And this is a sign that the myocardial blood flow has gone down. And this is shown in this study from University of Virginia, that the velocity goes down in patients with microvascular disease. And this is also shown in another study from University of Nebraska, that if there's perfusion abnormality with normal wall motion, the outcome is bad, meaning these patients have got microvascular disease. So these are the two important, components of when you do a stress echo. Not only look at wall thickening, but look at perfusion. Then your sensitivity goes up, and you can assess microvascular abnormality. Now, this is also has been now advocated in this recent consensus statement that was published again a few months ago, where it says you look at A, B, C, D assessment, meaning A meaning A synergy along with perfusion. So again, this emphasizes that you should do along with perfusion. And I'll come to the rest of it a bit later. So this is just to emphasize that it is in the guidelines, and this is also now in the ESC 2024 guidelines as class 1A indication that you should assess not only wall thickening with contrast, but also perfusion with contrast. So all the three you can see is in the guidelines, classed as not class 1A, but class 1B. So moving on, now, have we actually then come to the peak of what we call stress echo? No, we haven't, because this study showed that with CT, you can look at non-obstructive disease, atherosclerosis, and that has an important impact on outcome, because if you don't assess non-obstructive atherosclerosis in a patient with no ischemia, the outcome of that patient may not be that good in the long term, right? So one should have a mechanism by which one can assess atherosclerosis, even in absence of obstructive disease. And that we can do with looking at carotid artery. As you can see, the carotid artery is a mirror image of what's going on in the coronary arteries to some extent, as has been shown in this study, where you can see it's 5,800 patients were assessed in this, where all patients underwent both carotid atherosclerosis, carotid imaging, and coronary CT. And you can see when they looked at outcome, the top panel is for carotid atherosclerosis, the bottom one is for CT. You will see that all the lines are very similar in terms of predicting outcome. So you can see there's hardly any difference between the two. So meaning carotid artery assessment actually can give you prognostic data similar to CT. And so we did a study simultaneously with stress echo, first to see whether we can do it. Yes, we can do it. We can assess all patients for atherosclerosis with carotid soon after the exercise or stress. You look at the carotids and you can assess the plaques. So just the assessment of plaques is important. And when we did that, we found that if you see the top two panels are patients with normal stress echo, the outcome of normal stress echo, as I've said, is very good. It's 0.9%. But if the patient has atherosclerosis, in patients with normal stress echo, the outcome is worse. You can see the outcome, the heart event rate goes up to 0.9% versus those who did not have any atherosclerosis in a patient with a normal stress echo. So that is the importance of combining atherosclerosis with stress echo, and this is a long-term data on, of 7 years showing exactly the same, the incremental value of having to look at carotid atherosclerosis. So that will give us an assessment of perfusion, wall motion abnormality and atherosclerosis. And on top of that, you can also, with contrast, look at new revascularization, which is also shown to improve outcome assessment, as shown on the paper here, beyond just looking at the plaques. So these are all newer things that we can do with stress echo today. And this is the study that we are conducting today, a randomized study comparing stress echo with with carotid ultrasound versus CT to show whether actually it is non-inferior to CT, both for detecting obstructive disease or non-obstructive disease. So by the end of next year, we'll be able to publish this data. We are now more than halfway in recruitment. So now let's come back to what I've just mentioned very briefly. So the ABCD protocol. Now, what it is that A means you're looking at A synergy for ischemia, right? And B is where you are looking into the lungs. With the same scan, you can quickly assess the lung fields to look at B lines, which reflects pulmonary edema. So patients who exercises or undergoing dobutamine, you can quickly look at the lungs to see whether the patient is developing increase in LV filling pressure. So this is a marker of LV filling pressure, B lines. And then C is where you look at the contractile reserve of the left ventricle by actually looking at force-based contractile reserve, not just change in ejection fraction. So it's systolic blood pressure divided by end systolic volume will give you force-based contractile reserve, which you can see on the right-hand column is a measure of outcome also. And then you can also look at the LAD. You can actually look at the left anterior descending artery during echocardiography by placing the transducer in a more oblique way, and you can put the Doppler, the sample volume, on the LAD territory, and you can in the LAD actually, and you can assess velocity at rest and during stress, and the ratio gives you the coronary flow reserve. Coronary flow reserve of less than 2 suggests that the patient has a worse outcome, meaning they may have coronary disease, or they may have microvascular disease, or they may have other condition giving rise to low coronary flow reserve. And then finally, you can also look at heart rate reserve, meaning when the patient exercises, what's the ratio between the increased heart rate divided by the rest heart rate? So heart rate reserve, that also has got prognostic importance. As you can see on the right, the larger number of markers which are abnormal, the worse the outcome. So this also you can implement in your stress echo lab. And we can go beyond looking at coronary disease. Now we can look at, as I think it will be described in our subsequent lectures, looking at patients with aortic stenosis, assessing gradients, looking at mitral regurgitation, looking at assessment of right ventricular function, and looking at assessment of heart failure with preserved ejection fraction, HFpEF, in stress echocardiography. And so just if for 1 minute, I'll just talk about even future advances. So what I've talked about now is what you can do today, but what you can even do tomorrow, and that is high frame rate contrast imaging, not only for looking at intraventricular hemodynamics. You can see how well you can see intraventricular hemodynamics, both at rest and stress, but also look at myocardial perfusion. And we've published this data very recently on 25 patients with coronary disease, and we've shown that with high frame rate, you can see perfusion abnormalities much clearer, more intense, and also larger perfusion defect compared to the conventional MCE that we do today. So this is an example of the inferolateral ischemia. You can see the large amount of ischemia compared to conventional echo, and you can look at multi-vessel ischemia occurring in this patient, where with conventional MC, you may just miss it to in a multivessel disease, as you can see here on the left, and you can see that large LAD ischemia with high frame rate imaging. So this is another step forward, making stress echocardiography very sensitive in picking up coronary disease. And this is finally, I think it would be a gold standard now, in the future at least, that it's not enough to look at indirect markers of microvascular abnormality, but you can look at the microvasculature directly by using super resolution ultrasound. And you can see here, this is just B mode, right? You don't see very much here, just some speckles, but you begin to see now microbubbles within the myocardium as we do. But not only you can see the microbubbles within, but now you can look at capillaries. So what you're seeing is actually microvasculature here. And you can see the bubbles within the microvasculature moving in different directions, as you can see here. This is now in comparison with CT. And see, look at the blue and the red. So these are the microvasculature with velocities moving, one moving towards the transducer, one moving away from the transducer. So in short, today, we can look at atherosclerosis. We can assess hyperemic flow with either myocardial contrast echo or with Doppler assessment of the LAD. We can look at perfusion abnormalities with myocardial contrast echo, assess diastolic dysfunction with B lines, and we can look at regional wall thickening abnormality, contractile reserve, and we can assess ST changes. They all have prognostic importance. Thank you. So, so what we are going to do now, we are going to take questions. Let me unshare first. Just 1 second. How do we unshare? Okay. Oh, sorry.
I think questions can be in the end, Manish.
Yes, yeah, we'll take the question in the end.
So we'll have the presentations first.
Yeah. Okay, fine. So we'll move on to the next presentation. And so the next presentation will be by Professor Nitin Burkule from Mumbai. And he's going to talk about stress echo in chronic coronary syndrome. Nitin, the floor is yours.
Yeah. I'll just share my screen.
Nitin is like Roxy, what is in UK? So Nitin in India.
No.
Master
Yeah.
of stress eco.
I think that is not a comparison at all. Okay, so I think I'll just share my screen. I think the slides are visible.
Yeah.
Yeah.
Thank you, Professor Roxy Senior and Dr. Satish Parashar. I will be talking on the stress echo in the chronic coronary artery disease, and especially in this era of indiscriminate use of CT coronary angio. So, as we know that in the population, we have got a large pool of patients asymptomatic without known coronary artery disease, and we risk stratify them by using the ASCVD risk scores. However, some of these patients become symptomatic, which are new onset of symptoms of chest pain, which are suspicious of ischemic heart disease. Some of them present very acutely with the biomarker rise, and we treat them as the ACS. However, some of them get just settled as stable angina of effort or very low risk unstable angina. Some of them progress to patients who are asymptomatic but now with a known coronary artery disease because of imaging. And some of them again come back to a new onset of symptoms. So the stress echo is very useful for this group of patients who have got this new onset of chest pain, suspicion of coronary artery disease, and also who have stable angina of effort. And we use it for the validation of the symptoms, diagnosis, prognosis, and try to get a threshold of ischemia for the decision of revascularization. So currently we are still struggling with these two concepts, whether it is the ischemic burden, which is a predictor of adverse events, and is there a threshold beyond which the revascularization improves survival. And the ischemia trial has given us a very negative trial about this. And then or there is a systemic inflammation and vulnerable plaque, which causes the acute ACS, and that may be the reason of death and MI. And that is why probably asymptomatic patients and the revascularization has not improved the hard endpoints. With this background, we will go ahead with some very basic things about stress echo. That the choice of stress echo over stress ECG, the indications become stronger if the patient has an intermediate or high pretest probability, if ECG is uninterpretable, if there is an inability to exercise, or there are resting LV regional wall motion abnormalities, then women, and also in patients with this established CAD where we want to know the significance of stenosis or culprit lesion, or to detect incomplete revascularization and viability. So what is a normal response on stress echo? As we know, it's a uniform hyperdynamic motion, increased velocity and systolic thickening, and increase and the 1 minute, let me just go ahead. Yeah, and improved LV ejection fraction and the reduced LV and systolic volumes, and intense contrast perfusion in the myocardium. And what is a positive test? You develop a new regional wall motion abnormality like this, and you have got reduced systolic thickening in that territory. There is a fall in the global EF. There is an increase in the LV end systolic volumes, and sometimes there is a wall thinning, and you get endocardial perfusion defects. Now, with this, we'll also get this concept of wall motion scoring. One is a normal or hyperkinetic, two is hypokinetic, three is akinetic, four is dyskinetic, and you give this number to each segment and divide it by 16, the 16 segments that you see, and you get a wall motion score index. Now, with this, we'll look at this case, 39-year-old male who had monomorphic VT. There was no ACS, and you can see that the left panel will always be the rest and the right panel will be the peak exercise, and we can see that all the walls are showing hyperdynamic response and good systolic thickening, and all of them get number 1 point, which is hyperkinesis, and 16 divided by 16, the wall motion score is 1, which is normal, and his angio as expected is normal. So let us look at this 32-year-old gentleman who has got an impaired glucose tolerance, non-smoker. He had atypical chest pain and intermediate pretest probability, and this is his stress echo. As you can see, the left rest and the right peak, and we can see that there is a apical dilatation, no systolic thickening in the LAD territory, as you can see here. And if we want to give the, and this is this angio showing an LAD proximal stenosis. So this is a positive stress echo. And how do we refine the outcome? We can look at the wall motion score for this particular case, and we can give 3 points to the apex and 3 points at the mid septum and the apex. And if we add all of them together, it is 29 is the numerator divided by 16, and we have got the wall motion score index of 1.8. Is it really required to calculate the wall motion score index? Definitely, because we have a lot of prognostic data about positive stress echo, and we can refine the outcome by looking at the wall motion score index, the resting wall motion, and the peak stress LV end systolic volume. In this study, more than 5,500 patients, as the wall motion score index went on increasing, there were almost linear increase in the cardiac events per person year. So also in this case, in this study of 4,000 plus patients who had a normal stress ECG, if you have a stress echo positive, that means if your regional wall motion abnormality at peak exercise, then the mortality and the MACE events almost double if you have a normal ECG with no regional wall motion abnormality. This is a retrospective study of more than 3,000 patients, and as we see that as the wall motion score index increases, the cardiac event rates per year go on increasing. So this can act as a gatekeeper for the invasive coronary angio. So also the same study of more than 3,000 patients, but retrospectively showed that the cardiac event rates on medical management are shown in the red bars, and the cardiac event rates in the patients after revascularization is shown by yellow bars, and the major change occurs only when the wall motion score index is very high. So probably there is some threshold, though obviously the ischemia trial has not given us a threshold, but probably in the real world, we definitely have some threshold. As the wall motion score index goes on increasing, probably the revascularization may be beneficial. Let us look at this case, a 63-year-old gentleman who had dyspnea on exertion, which was new onset in the last 5 to 6 months. He had CABG done 12 years back. The recent graft angio showed patent lima to LAD and SVG to RCA, which were the two grafts put. He's ex-smoker, he's non-hypertensive, non-diabetic. And this was his ECG stress at rest, and this was his stress ECG. The ST elevation is only in the Q leads, so it is not of much use. And this is his stress echo, and you can see that these are the rest images. You can see on the right side, which are the peak exercise images. There is a definite LV dilatation, and there are multiple areas of regional wall motion abnormality. So despite having the graft patency, he has a acute cardiac dilatation at peak exercise, and it's very much evident here. This is his angio, which shows the native disease has not progressed, and there is a competitive flow in the LAD. And this is the graph to the RCA, which is perfectly working fine. And this is the graph to the Lima, which has got one intercostal vessel there, which may be causing some still. But however, there is a very good opacification of the distal LAD. Then who is the problem? Just getting the catheter down, and you can see that there is a very, very tight stenosis in the left subclavian artery. So though there was a graft patency, actually the left subclavian artery had a very critical disease, and that was causing this global ischemia. So again, if we look at the wall motion score index in this patient, it is 2.3. And if we look at the resting volumes and the peak exercise volumes, we see that there is a definite increase in the LV end systolic volume from 78 to 97 ml at peak exercise, and there is a 5% drop in ejection fraction. Now, this is also has a prognostic importance, as we can see in this study of more than 2,500 patients, more than 65 years of age, long-term 3 to 5 years follow. As the wall motion score index go on increasing, as shown by from green to yellow to red lines, the event-free survival goes on reducing. And so also, if we look if there is no change in the LV end systolic volume, or there is an increase in the LV end systolic volume at peak exercise, then the event-free survival goes on reducing, as shown by the red lines. So also this study showed that if you look at the patients where there is no change in the end systolic volume, or there is an increase in the end systolic volume, then the cardiac death, non-fatal MIs, and the late revascularization go on increasing. The event rates go on increasing. So if there is an inability to reduce the LV end systolic volume at peak exercise, that itself is a very important prognostic marker. Now let us look at this case, 58-year-old female, obese, sedentary, non-diabetic, hypothyroid, atypical chest pain, intermediate pretest probability, and this is a dobutamine stress echo. And there is a clear-cut akinesia in the apical territory here, and the same thing is seen in the mid and apical septum, and also all the apical territories. And as expected, her angio shows a very significant ostial LAD disease. So the dobutamine stress echo, if it is negative, actually the cardiac mortality is just less than 1% per year. However, if you have got an ischemia on dobutamine stress echo, or if you have a resting scar, the cumulative survival goes down. And if you have got both ischemia and scar on in a DAC patient, the event-free survival is worst. So everything has got an extremely good prognostic value in stress echo. How do we improve the sensitivity of our stress echo? One is that you can do imaging on the treadmill, or of course, in a stationary bike. Obviously, you can do it on while you are doing the exercise. But in treadmill, most of us are doing post peak exercise. But you can do the imaging on treadmill. Use LV opacification contrast. Look at the LAD CFR, and look at the ischemic memory on the post-peak exercise, and can use myocardial contrast echo. So let us look at each of these examples. If you do a peak exercise treadmill, that means you do the imaging on treadmill, versus if you do it at peak supine bicycle, or whether you do it post treadmill, that means the patient comes back to the bed and then you do the imaging, you can see that the sensitivity is highest when you do it on treadmill. And this is because obviously you achieve the highest workload on the treadmill than the supine bicycle. This is at a loss of little specificity, but the overall accuracy is better on peak treadmill echo images, and most of the time you get very good quality of images, and the good quality in this particular study, the quality of images was similar whether it was peak or it was post treadmill. Now about the LED CFR. Now this was our patient who was sent us to know the significance of this proximal LED plaque. As you can see here, because this was because there was no online, the FFR was not measured in the cath lab. So there was an ostial LED plaque, and here we can see the LED flow. And this is the basal diastolic flow in the LED, and this is after giving adenosine. And you can see that there is a definitely more than twice increase in the velocity time integral of the LED flow, telling you that this is definitely not a physiologically significant plaque. In this particular study, more than 650 patients with normal stress echo, if the CFR was more than 2 versus if the CFR was less than 2, the cumulative survival was worse if the coronary flow reserve was lower. Now, one would say you are only looking at a coronary flow reserve of LED, but however, that is a marker of the entire endothelial function of the coronaries. So even if normal regional walls, if you have a CFR which is low, gives you good prognostic data. So if you put this in this chart of sensitivity versus specificity, as we know, the wall motion has a very high specificity, but a lower sensitivity, as you can see here. But if you put this wall motion and CFR together, then the sensitivity and specificity is quite optimal. Now let us look at the ischemic memory, and this is what in the animal experiments it has been shown that if you occlude the coronary and then reperfuse it, then the strain curves show a post-systolic shortening and much delayed relaxation. Generally, within the 1/3 of the diastole, there is a significant relaxation in the myocardial contraction or the myocardial deformation. However, a post ischemia, even if the regional wall motion improves, there continues to be a very delayed relaxation, and the relaxation doesn't complete in the first 1/3 of the diastole. And this ischemic memory lasts 5 to 7 millimeters post exercise, and you have got a lot of time to get good images when the patient is not hyperventilating. And importantly, that the same myocardial segment at rest can work as its own control after the exercise. So we'll look at this gentleman, 43-year-old male, a strong family history of ischemic heart disease, chest heaviness during morning walk, non-smoker, and impaired glucose tolerance. And this was his resting echo, which was fine. And then he has this strain at the rest, and you can see all the peaks at the same time, and they are quite synchronous. And then he exercises. This is rest ECG. This is peak exercise ECG showing ST depression. And this is his peak stress echo. And we had a hard time to actually point out the regional wall motion abnormalities in this particular patient. Though one can see that there is no reduction in the LV volume for sure. So this is definitely an abnormal stress echo. But now we look at the same patient after 7 minutes, and this is when you can see the bubbles have died down, and this is after 7 minutes. And if we look at the strain curves, you can see that the strain curves coming from the inferior septum are actually showing a stretching in the early systole, and there is a post-systolic shortening, and there is a failure of diastolic relaxation more than 1/3 of the diastole. So definitely there is a significant thing happening in the right coronary territory, and this is his angio. Non-obstructive disease in LED, but the RCA is filling up retrogradely, and RCA is 100% occluded. So let us look at the stress echo, how it fares in the era of CT coronary angio, and I'll show you some practical cases. This is a 54-year-old doctor, non-diabetic, non-hypertensive. He had undergone a CT coronary angio just as a routine. Many people do it as a fashion, and it was perfectly normal done 2 years back. Now he comes with chest pain on exertion, and he was turned down from the cardiologist's office because your CT angio was just normal a couple of years back. He has a normal stress ECG. He has normal ECG. What we did was, this was his, we made him climb 1 or 2 staircases, and this is his echo. And if we look at these strain curves of this patient, as I told you that this is the transverse strain, which shows a complete resolution within the 1/3 of the diastole. What happens during the post ischemia, that there is a significant reduction in the diastolic relaxation in the first one-third of diastole. And we can see for this particular patient that just going up and down the staircases, you can see that the strain curves coming from the apical territories are showing a significant post-systolic shortening and a very delayed relaxation here. And this is his transverse strain, which also shows the same happening in the first one-third of diastole. And he has got a very significant proximal LAD disease. Now, this brings to the question, is there a warranty period after normal CT coronary angio? Most people feel that 5 years you don't have to really worry. And as actually Dr. Roxy's data showed that 5 years after stress echo, you really don't have to worry. Your mortality is less than 5%. Now, CT coronary angio, you can see that within 2 years, this patient had developed a very critical disease. And the thing is, there was a delay in diagnosis because of an extreme faith in the negative predictive value of CT coronary angio. And most of the time, the retesting is not feasible when the patient develops new onset of symptoms. And here the functional imaging is so important, because the functional imaging, you can keep on doing retesting and retesting without exposure to radiation or any harmful chemicals. Let us look at this other case. A 49-year-old male marathon runner, no risk factors. He felt uneasiness while he was training. And he came for a routine consultation immediately after finishing his training of running some 15-20 kilometers. The troponin was 0.03, 0.01 was the upper limit. Now, mild rise in troponin is well known in the marathon runners who are the extreme runners. So this was not very possible. This was not. So he went for a CT, and so that the CT score was the 1000. Actually, that itself tells you a significant atherosclerosis. Despite that, the CT coronary angio was proceeded, and there was a heavily calcified left main bifurcation, and it was thought that there is a very critical TVD. And there was no, and this guy is running 15-20 kilometers every week. And then he was, his report showed a very critical left main bifurcation and RC disease. So we thought that we have to have functional testing in this patient. So we went ahead with the stress echo, and this is resting ECG, this is peak exercise echo ECG, and this is his peak stress echo. Now, the first thing you can see that the apex is contracting really vigorously, very unlikely that he can have left main bifurcation disease. But however, there is definitely inferior septum and inferior wall are akinetic, telling you that the RCA ischemia is definitely there. And so also you can see in the short axis that you have got an inferior wall akinesia. So definitely one thing is sure, that the left-sided disease is not functionally significant. As you can again see, there is a significant calcification, but non-obstructive disease on the left side, while his right coronary showed a very critical right coronary disease. Actually, I think it didn't play, but a critical disease in the right coronary, and he went ahead with the stenting. And next 12 years, he never had any symptoms. So though the CT coronary angio has got a significant negative predictive value, its positive predictive value for obstructive coronary disease is very poor, just 53%. So it excludes CAD very well, but at a cost of overestimation of obstructive coronary artery disease. So the anatomical imaging doesn't differentiate an incidental CAD versus a symptomatic CAD. And so also the optimal revascularization, if you want to do for a culprit vessel, then you have to fall back on functional imaging, or you have to fall back on anyway the functional coronary imaging like FFR, or at least the functional imaging like stress echo or stress CMR. So the CT imaging in this particular case was actually superfluous. It was actually superfluous. So we have another case of 44-year-old gentleman who runs 4 kilometers 4 kilometers every day, 5 times a week. Strong family history of premature coronary artery disease, light smoker, hypertensive. Now clinical investigations were done for life insurance policy, and that life insurance policy mandated to have a CT calcium score, and that was more than 75th percentile. So that led to CT coronary angio as usual, and it showed significant tipple vessel disease for a person running 4 to 5 kilometers every day. Now, this was a CT coronary angio which was touted to have this thing. And obviously, with this kind of a CT report, a very concerned patient and his physician went for an invasive coronary angio, and it showed a non-obstructive coronary artery disease in the left segment, and so also on the right coronary segments. Okay, so we went ahead with the stress echo, and you can see that this is his 11 minutes on Bruce protocol, and this is his stress echo. Peak exercise shows reduction in the end systolic volume, hyperdynamic wall motion in all the coronary territories, and we told them that don't go ahead with any kind of invasive procedures, because we know that if you have a negative stress echo, you have an excellent survival. Suppose this is the survival graph of of your peers, and if you have got a stress echo which is normal, you actually have a better cumulative survival. And as we know that if you have got a negative stress echo, then your 5-year death MI is 0.5%, and the prognosis is same whether it is male or female. So negative stress echo is really useful. So CT angio generally leads to more invasive coronary angios and more interventions. And this is what was shown in the PROMISE trial, that if you see that the invasive catheterization was much higher, 4% higher in the CT coronary angiogram versus the functional arm, because this particular PROMISE trial was to look at the outcome of functional testing versus CT coronary angio, and you can see the invasive catheterization was 4% higher in the CT angio arm, and that led to more revascularization, about double the revascularization, both PCIs and CABG, and this was without any change in the CV mortality at end of 2 years. So what happens is the CT picks up a significant atherosclerosis, which could have missed on the functional testing. So one would argue that this patient, since he had a CT coronary calcium score high, if you had just done a stress echo, you would have missed the opportunity of starting statins in this patient. But let me look at this patient a little more carefully as his ACVD score. So he's a 44-year-old male, current smoker, systolic BP 130, on antihypertensives with total cholesterol of 200 and HDL 40. If you put into the ACVD score, it is 8%. Now that, coupled with his history of premature family history and a CT calcium score high, would have anywhere given him high dose statins, and he would have been eligible for the optimal medical therapy. You would not have, he really never required a CT coronary angio, which unnecessarily led to invasive coronary angios and then more worries for this patient. So this is how I think quickly last few cases. A 58-year-old male, atypical chest pain on exertion, diabetes for 23 years, on insulin, non-hypertensive, non-smoker, and this is his stress echo. And we can clearly see that there's an increase in the LV end systolic volume and akinesia of the LV apical territories entirely in the LAD territories. Okay, and definitely a positive stress echo, and his coronary angio is absolutely clean. You do not see any kind of a disease here in the coronary disease, and so also on the RCA. So is it a false positive stress echo? Okay. Now, if we look at again the PROMISE trial, you can see that the false positives were less in the CTA arm, and that is obvious because it's anatomical testing, while the chances of having a non-obstructive disease was higher because the false positives were higher. But what the functional testing show you is a false positive. Is it really a low risk group? Definitely not. If we look at the outcome of the false positive stress echoes, as I showed you here, this particular study from Mayo showed that if you look at the true positives and the false positive stress echoes and DSEs, actually the curves follow very close to each other. That means they are not at all benign things. The false positive stress echoes, that means stress echo showing peak exercise regional wall, but your coronary artery shows non-obstructive coronary artery disease. Why? Because we are probably unmasking subclinical cardiomyopathy, or it can be an epicardial coronary endothelial dysfunction, or it can be a functional disease at the level of microvasculature, or it can be a stress test induced variant of Takotsubo. And these patients have a higher probability of developing a stage B heart failure, or overt heart failure, or atrial fibrillation. So a false positive stress echo, a functional testing, this is definitely missed by the anatomical testing. And as we have seen that despite the CTA leading to more invasive angiography and more invasive procedures, at the end of 42 weeks or 42 months, the event rate was the same, whether you started with the functional testing or whether you started with the CT coronary angio. And now let us look why we have a lot of low sensitivity in stress echo as compared to CT-CAG as showed in this EVINCI study. The reason is that although your specificity is absolutely matching, the reason is that the what is the false negativity due to? In this particular study, it was a submaximal load in almost 40% of the patients, anti-anginals in 1/4 patients. The imaging quality was poor in 55% of the patient, which we can take care of with the LVO size. And if we achieve a good workload and if we keep the patient off anti-anginals during the test and have a good image quality using contrast, probably we can improve the sensitivity significantly. And this particular study of 11,000 patients showed that if you have a negative stress echo, but if you have got a submaximal exercise, then your event rates are higher. That means you have missed a lot of disease. So the maximal stress echo is shown by the yellow bars and the red bar shows submaximal stress echo. Though you have negative stress echoes, but if you are not achieved the maximal workload, then the event rates are definitely higher. So my last slide, that finally why the functional testing is so important despite having a CT angio showing you anatomical disease. What if there's a negative CT coronary angio? Despite that, you would probably require a pharmacological stress echo for a vasoactive angina. You may need a stress echo to look at the cardiomyopathic response, as I showed you in this patient with diabetic cardiomyopathy, probably subclinical diabetic cardiomyopathy, or you may need a echo for the other cardiac structural and functional evaluation as a cause of the patient's symptoms. So, which are definitely beyond the anatomical imaging. What if the CT coronary angio is positive? Despite that, is it an incidental CAD? The symptoms of the patient may not be actually related to the coronary disease. For that, you anyway need stress echo to validate the symptoms or there is symptom corroboration. Stress echo also is needed to look at the prognosis because you have exercise data, you have got cardiac dilatation data, you have got symptom data, you have got ECG data, and so on and so forth, and the wall motion scoring index. And stress echo is also useful to know which lesion is significant, even if you have a CT coronary angio showing TVD. So finally, I think stress echo still stands the test of time over the years, despite very easy non-invasive anatomical imaging. So if we look at this particular hierarchical difference between the stress echo and CT CAG, we can see that in the therapeutic strategy, clinical outcome, patient satisfaction, and the cost, stress echo definitely has an edge. Thank you.
So it was a, so now from a coronary artery disease, we come to the valvular lesion, and that's very important topic. What is the role of a stress echo in aortic valve disease? And Dr. Senior will show some of his experiences and slides. So, Professor Senior, please.
Dr. Roxy, you'll have to unmute yourself, please.
Yeah.
Dr. Roxy, sir, you will have to unmute yourself.
You can
Yes.
hear me now?
Yeah.
Yeah.
Yes, sir.
Okay, the problem is when the screen comes up, I can't see any icons of muting, unmuting, and also my video, I can't put it on now because I can't see. You can't put it on from your end, right? You can't make it. Anyway, it doesn't matter. We'll come back later. Okay, so my topic is on, yeah, thank you. Yeah, so my topic is on stress echo. So it'll be mainly based on cases and, what are the nuances of doing stress echo in aortic stenosis. So let's go to the first case. Okay, my slide is not moving now. Okay, fine.
Yeah.
So let's go look at this case. So 77-year-old female with known asymptomatic severe AS with the mean gradient of 46 and aortic valve area of 0.6. So as we all know that we need to be sure that patients who come in with severe aortic stenosis, who says I'm fine, we still need to do a test to objectively know whether the patient is asymptomatic or not. And secondly, also to see whether there are risk markers on these patients that will result in this patient having an intervention. So we look at hemodynamic criteria like hypotension, and then we look at arrhythmias, we look at ST changes. Now, in this particular patient, none of that occurred. So let's move on now. So let's look at the Doppler data. So the patient exercised, as I've said, for 4 or 5 minutes on Bruce protocol, 77 years old, little shortness of breath, but nothing much. Blood pressure response was fine, no arrhythmias, and no symptoms. And you can see that the mean gradient increased from 46 to 56. And also, if you can also see that the mean gradient has increased, everything is okay. But when we quickly calculated the stroke volume index, it has come down. Now, stroke volume index may come down during stress, not because of anything else, but because of the fact that when you exercise, stroke volume can drop during exercise because the LV becomes smaller, filling time becomes smaller, and therefore, the stroke volume can drop and it's not, and it is not pathognomic. However, when we calculated the flow rate, which is stroke volume divided by ejection time, it dropped to 203, but the patient was asymptomatic. So what is the cause of that? So now if you look at the quad screen here, you will see that, okay, so on the left is rest, on the right is stress. You can immediately see that the LV is dilated. But you will also appreciate not only the LV is dilated, but there is regional wall thickening abnormality affecting the septum, the apex, and even the apicolateral wall. And in the three-chamber view, you can see the same. Much of the septum is severely hypokinetic. So this type of response can occur even in presence of, in absence of any coronary disease. It can also occur in patients where the gradient goes up very quickly and the increased afterload can result in LV dilatation. But usually you won't see regional wall motion abnormality as you see here. So this patient underwent an angiogram, and the angiogram seems to be not playing. Anyway, this patient again has significant LED stenosis. So what does this tell us? So first of all, it is recommended in the guidelines that when a patient comes with asymptomatic severe aortic stenosis, you should assess symptoms, etc. But also, the echocardiography does provide additional prognostic information in terms of increase in mean gradient of more than 20. That has been shown to predict chances of this patient developing symptoms very quickly. And also one should assess the change in LV function. So all these are very important when one assesses a patient with asymptomatic aortic stenosis. So let's move on. So this is another patient who's 88 year. Let's see. Yeah, let's look at this. 88 years old female with known ischemic heart disease, a recent diagnosis of aortic stenosis, and the patient is symptomatic. You can see the patient is very elderly, had a pacemaker put on because of tachycardia syndrome, but the patient is symptomatic, and there's a diagnosis of AS. So if you just look at the hemodynamic data, resting hemodynamic data, the patient has a mean gradient of 24, and you can see that the let me actually get the screen. Just one second. Yeah, the patient has a flow rate of 179 ml per second, meaning it's reduced. The aortic valve area is 0.7 and the mean gradient is 24. So this patient has a low flow aortic stenosis, which is, and with a normal ejection fraction. So it's a paradoxical low flow, low gradient aortic stenosis. So we went ahead with dobutamine, low dose of dobutamine. So this is intermediate dose of dobutamine, about 10, right? The mean gradient remained about 23, and the flow rate improved very quickly to 260, and the valve area exceeded 1 centimeter square, so 1.05, and mean gradient was 23 at the intermediate stage. But the question is, why is the patient complaining of shortness of breath? We have excluded other causes of shortness of breath like lung pathology and all that. So the question is whether the patient has got myocardial ischemia. So we increase the dose of dobutamine. And so as the reasons what I've stated, so we increase the dose of dobutamine. So now what did we find? The mean gradient obviously remained the same or didn't increase very much, but the flow rate actually dropped to 204 ml per second instead of being, what it was, 240 or something. So it was surprising to see flow rate dropping quickly. We looked at our images. Now, so this is the image, rest, and this is on stress. So what you can see here is at peak stress, there is an abnormal septal motion. And this is very much suggestive of a Leb-Mann-Brunch block pattern. Now, what happened was the patient at rest was not pacing, but during stress, she started pacing. At high load, the patient started pacing. And as a result of which, the LV is now dysynchronous. And though the wall thickening is maintained, the stroke volume, the flow rate dropped as a result of that. And so in this particular case, we could make a diagnosis very clearly that the patient does not have severe aortic stenosis, neither does the patient have myocardial ischemia, but essentially we have to now really see what other causes of breathlessness the patient might have at this age. So now let's move on to another patient. So 82-year-old female, shortness of breath on exertion, myelodysplastic, anemia, echo showed clearly, a reduced ejection fraction, as you can see. And also, if you look at the aortic valve, it is very thick and not opening very well. And you can see this appearance in a low flow state. However, this patient had an ejection fraction of 35%, which is low. But if you look at the flow rate in this patient, the stroke volume is 91, right? And the flow rate, which is about 260 ml per second, and you can get a normal flow rate on even normal stroke volume in patients with a dilated LV, and reduced ejection fraction, because the volume that is ejected may be high, though the efficiency of the left ventricle is low. So you have a high flow rate here. So it's a normal flow rate. So with this normal flow rate, we are getting a mean gradient of 32, right? And we are getting an aortic valve area, mean gradient of 32, and the aortic valve area was 0.9. So again, the question is, does this patient have severe aortic stenosis? So we gave dobutamine. So during dobutamine, you will see that the stroke volume actually did not change very much, from 91 to only 10%. So essentially what it's saying is that the patient doesn't have flow reserve according to guideline criteria, right? However, when we looked at the LV during stress, you can see that the LV is actually contracting pretty well. The ejection fraction is improved to 48%. And if you look at the mean gradient, it has jumped to 54 millimeter of mercury. So in summary, the stress echo has shown that the ejection fraction has improved, the flow rate has gone right up to 333 ml per second, while the stroke volume reserve is only 10%. So what is not right here? And obviously, the patient has severe aortic stenosis because the mean gradient has gone up to 54 and the valve area is less than 0.91. So remember, when the patient has a low ejection fraction, your colleagues, the surgeons, if they're doing surgery, will ask you, okay, this patient's got poor LV, what is the contractile reserve? Now you will be a bit stuck, isn't it? You'll say, well, stroke volume reserve is really low, and according to guidelines, it is not good. So this is a study that we did where we said the lack of stroke volume does not preclude the diagnosis of severe aortic valve stenosis. So this example has shown that there was no stroke volume reserve, and yet the gradient went up remarkably, and we could make a diagnosis of severe aortic stenosis. So how did the gradient go up without any increase in stroke volume reserve? Now, if you look at this Doppler signals here, so this is looking at the LVOT. You can see that the LVOT at rest and LVOT at peak, the stroke volume did not show much of a difference. However, what you see here is, the way we calculate stroke volume, as you all know, is LVOT area multiplied by VTI. So it is a VTI that we are looking at. So the VTI is very similar. So what is the difference between this VTI and this VTI? The only difference is the increase in velocity in the patient in this trace compared to rest, right? You can see that the velocity has increased significantly during peak stress. And this velocity is what drives the aortic valve to open. And a marker of this increase, or rather, the way we express this increased velocity is by calculating flow rate. So if you multiply mean velocity by LVOT area, you'll get the flow rate, or you can measure the ejection time and divide it by stroke volume, and you'll get the flow rate also. So both methods you can use. But essentially what this shows is the reason why flow rate has gone up is because the velocity has gone up, and it's the velocity which is making the valve open. And so why did the stroke volume did not change? As I've told you before, when the heart rate goes up, when there is tachycardia, the filling doesn't change very much, and the volume can get smaller, and therefore the stroke volume will not change, and you will erroneously make a diagnosis of lack of stroke volume reserve, presence of stroke volume reserve. But stroke volume reserve, therefore, is not a good criteria for contractile reserve. And this data shows also why now recent data suggests that there is no prognostic value of stroke volume divide flow reserve. And these are three studies, one published from the Japanese group, one from Pibero's group, and one from our group. And we all showed the same, that stroke volume flow reserve has no prognostic marker. And we've also shown it doesn't even make any difference to how you diagnose severe aortic stenosis. And you can see from this study of ours that the stroke volume flow reserve is not prognostic, while the stress flow rate was prognostic. Because stress flow rate, as you saw, actually, you saw the increase in velocity. And the velocity increase represents circumferential myocardial shortening, which is a marker of intrinsic myocardial contractility. So stress flow rate is a better marker of contractile reserve than stroke volume stroke volume derived flow reserve. So let's come to the third case now. So this patient is a 79-year-old female, right, with a mean gradient who's got aortic stenosis. The question is the severity again, because the patient has a mean gradient of only 16, valve area is low. So this patient has got low gradient aortic stenosis, and you can see the flow rate is also low. So it's low flow, low gradient aortic stenosis, and also the ejection fraction is low. So it's a classical low flow, low gradient aortic stenosis. So this patient then underwent dobutamin stress echo, as we do. So I'm just showing you the data now. I'm not showing you the traces. So you can see in the data that with low and peak doses of 15 microgram, the aortic valve area did not change. The flow rate went up to 209. The stroke volume, again, you can see from 48 to 52 did not change very much. And you can see it remains in the low flow region, 26.2, 27.6, sorry, 27.6 and 28.6. And the ejection fraction also in this patient did not show any changes. The heart rate went up to 124. Now, so what is the diagnosis here? So if you just look at the data, it's a indeterminate condition. It's a non-diagnostic stress echo, meaning the valve area hasn't changed, the mean gradient hasn't changed very much. Well, it's increased from 16 to 31, but it didn't touch 40. The valve area did not change. So we remain in an indeterminate diagnostic, stage. So we don't know what the severity of aortic stenosis is. Now, one way to assess this is to calculate the projected valve area. So you can look at the data here. So you can project the valve area, having seen the data here. So so this is a formula that you can use, which you can read here. It's quite complex, but you can feed this into your machine and then it can calculate it for you. But essentially what it does is it projects the valve area to 250 ml per second flow rate and see what the valve area is at that point. If it's less than 1, then it is severe. If it's more than 1, then it is not severe. So it's a projected valve area. But the problem with aortic projected valve area is two. Number one, you have to do all those calculations. Number two, if the flow rate does not increase by more than 15%, then this method doesn't work. So in this case, you will see that the flow rate has increased from 164, 164 to 209. So it has gone over 15%. So you can use the projected valve area and come up with a diagnosis. But if the flow rate did not increase by 15%, you cannot use this technique. So what can you do then if the flow rate didn't increase by more than 15%? So this is the data that we published about 2 years ago, and we showed how you can use the stress flow rate as it is without doing any projection and make a diagnosis of severe aortic stenosis. So if you look at this data, first of all, what we showed is if the stress flow rate exceeds 210, then the outcome of this patient is good compared to if it doesn't. Secondly, what we've shown, if at that, so we call this normalization of flow rate of 210, the valve area remains less than 1, then it is severe aortic stenosis. And indeed, when we looked at patients who underwent aortic valve intervention and had this aortic valve area less than 1 centimeter with a flow rate of more than 2, the outcome of the intervention was better than the patient undergoing medical management. So in other words, the patient benefited from aortic valve intervention by using this criteria. So now using this criteria, if you had stuck to this guideline criteria, which we just described in this case, we would have made a diagnosis of severe aortic stenosis in 57% of the population. In 43% of the population, it would have been an indeterminate test, and you would have resorted to maybe calcium score or something. Even calcium score is not that accurate in low flow, low gradient aortic stenosis. So if you use the flow rate criteria of 210, then your detection of severity of aortic stenosis increases to 71%. So you can see you can detect now 45% as severe aortic stenosis and 26% in non-severe, and now the indeterminate drops to 29%. So you can drop the indeterminate from 43 to 29%, which is still not ideal. We want it to be even lower. How can we do that? So we came up with this idea. Why don't we now combine the projected valve area on top of this and see what happens? So when we do that, then the diagnostic test improves from 57 to 90%, and the increased detection of severe aortic stenosis from 29 to 61%, and the indeterminate AS drops to 9%. So in other words, and these patients, again, if you look on the right-hand side of the graph, when these patients, the newly reclassified severe aortic stenosis in the indeterminate group, when they underwent intervention, they did better compared to medical therapy. But those who did not satisfy the criteria of severe aortic stenosis but was showing moderate aortic stenosis, they did not benefit from intervention. While if you look at this here, that the patients who are indeterminate but reclassified, did somewhat worse compared to classical severe AS stenosis that you can come up with initially. That is because these indeterminate patients have a lot of other morbid factors that can make their outcome worse. However, if you intervene on these patients, they do better than medical therapy, as shown on the top slide. So in other words, you can intervene on even these patients and they would do better compared to medical therapy. So in conclusion, the take-home message would be to always assess LV function, regional wall motion abnormality, contractile reserve during stress echo for aortic stenosis. Stroke volume flow reserve should not be used because it gives you erroneous data because of smaller LV volumes during stress echo, and it's not a marker of contractile reserve. So don't use it. If stress echo is indeterminate, always assess aortic valve area at flow rate of 210, and if indeterminate AS persists, use the projected valve area. Now, calcium score is, of course, useful, but I'm sure you've seen many data showing that CT calcium score is not that accurate in patients with low flow, low gradient aortic stenosis. Thank you.
Thank you for showing some cases or so. I think before we go to the next case, the audience may like to know how easy it is to calculate the flow rate. Is it time consuming, or how much correct it will be?
You just divide the stroke volume with the ejection time, and ejection time is very easy to measure on the Doppler, right? So you divide so if the ejection time is like 272 millisecond, you divide stroke volume with 272 millisecond and just multiply by 1000 and you'll get the flow rate.
Good, thank you. So now we come to the next presentation by Dr. Manish Bansal. He is the Senior Director, Clinical and Preventive Cardiology at Medanta Hospital, and also one of the Chief of Intervention of this non-invasive cardiac lab. So we'll change the topic, and he comes to for a stress echo for hemodynamic assessment. Manish, please.
Yeah, thank you. I'm going to So I'm going to talk about role of stress echocardiography for hemodynamic assessment. So as we understand, stress echo is a very powerful modality because it has a unique advantage of showing a lot of hemodynamic abnormalities which no other diagnostic modality can do. When a person exercises, there is generally an increase in heart rate, there is increase in cardiac contractility, and intracardiac flow, stroke volume, and cardiac output. In a person who has healthy cardiorespiratory system, these changes in hemodynamics do not result in any abnormalities. But if the cardiopulmonary system is compromised, then depending on the site of this compromise, there will be abnormalities, like there may be increase in filling pressures of the ventricles and atria. It may result in inadequate increase or actual decrease in ventricular function, which may be global or regional. Valve gradients may increase. There may be new or worsening valve regurgitation. There may be increase in pulmonary pressures. Pulmonary congestion may occur. And other abnormalities may also arise. And all these abnormalities can be evaluated with the help of echocardiography and correlated with the symptoms. So this combined assessment in relation to symptoms is very, very helpful in terms of diagnosis, prognosis, and clinical decision making. And for this reason, stress echocardiography has a wide utility beyond just the recognition of coronary artery disease. We can use it for assessment of hemodynamic impact of CAD itself, but more importantly, stress echo is a very useful modality for diagnosis of heart failure with preserved ejection fraction. In the evaluation of valve diseases, we saw some very nice examples of aortic stenosis, but it is also helpful in the assessment of AR, MS, MR, both primary and secondary. It can be used for evaluation of cardiomyopathies, pulmonary hypertension, and some congenital heart diseases. So when we do stress echo for hemodynamic assessment, we want to use exercise as the stressor, and preferably semi-supine bicycle ergometry, because when we use semi-supine bicycle ergometry, we can assess low dose response and we can evaluate changes in cardiac function during exercise, unlike treadmill, where we can only assess the peak exercise response, and that too usually after the cessation of exercise. But if we don't have semi-supine bicycle, then using treadmill is the only option, which is what we mostly do in our country. Dobutamine is not generally preferred for most of the indications, except for some scenarios like aortic stenosis, as Professor Roxy Senior showed in his presentation, and sometimes in mitral stenosis also. Depending on what entity we are dealing with, the parameters that we want to measure will vary. So we may have to measure LV volumes and EF, LV filling pressure, transvalvular blood flow and gradients, severity of MR, TR, PA pressure, RV systolic function. We can assess RVPA coupling, lung congestion, and coronary blood flow. All of these abnormalities can be assessed, but we tailor it according to the need of the test. So this is a typical exercise protocol using bicycle ergometry. It shows how the stress level is increased in a graded manner and the different parameters that can be assessed. This is a summary of the key abnormalities that we see in various conditions where we are using stress echo for hemodynamic assessment, and the threshold values that define abnormality are also described here. For example, LVOT gradient more than 50 in case of hypertrophic cardiomyopathy, and then the gradients, contractile reserve for all the different conditions are summarized here. In case of valve diseases, we use stress echo mainly for two situations. In two situations, one is when the valve lesion appears severe, but the patient is valve lesion does not appear to be severe, but the patient is symptomatic. Or the other situation is when the valve lesion appears to be severe, but the patient is asymptomatic. And the third scenario would be in patients who are undergoing some major non-cardiac surgery or pregnant women, where we would want to assess the functional significance of the valve lesion. So in these cases, we look at the valve and the change in gradients. In case of stenotic lesions, change in regurgitant orifice area in case of MR. We look at the contractile reserve at the level of ventricle, hemodynamics in terms of filling pressure and pulmonary hypertension, and based on this, we make our decisions. So I'm going to show three different scenarios where we can use stress echo for hemodynamic assessment. So first example is that of mitral stenosis, which is a very commonly encountered entity in our setting. And many times we find patients in whom symptoms do not match with the severity, and then we end up doing stress echo. So how we do it? As I mentioned, exercise is the preferred mode of stress testing here. We may have to use dobutamine echo in patients who are undergoing non-cardiac surgery and cannot exercise because of the disease, or if the patient is very symptomatic. The main images that we want to obtain are continuous wave Doppler of TR jet, mitral stenosis gradient. These are the two main findings that we are interested in. And it's very important to acquire low stress images, but that may not be possible if the patient is exercising on treadmill. What we look for? We look for symptoms and exercise capacity. We look at the mitral stenosis gradient. If the gradient increases beyond 15 on exercise or more than 18 during dobutamine echo, it indicates significant mitral stenosis. We also look at PA pressure. If the PA systolic pressure increases beyond 60 on exercise, then it is significant. But the PA systolic pressure during dobutamine echo is not of much relevance. So here we have an example. This was a 38 years old gentleman, rheumatic heart disease, mitral stenosis, presented with significant dyspnea. So as we can see here, he has mitral valve disease, mitral stenosis, but the valve is opening reasonably well, and there's not much turbulence also at the level of mitral valve at rest. These are his parameters: mean gradient 6, TR gradient 32 at baseline at a heart rate of around 80. Valve area was 1.4 centimeters square by both planimetry and the pressure hub. Now at 1.4, we usually don't contemplate any kind of intervention, not BMV and certainly not surgery. But this patient was very symptomatic and it was important to assess what the cause was for his symptoms. So we made him do exercise. These are the baseline parameters. He was able to exercise only for 5.5 minutes despite being a young gentleman, developed significant dyspnea. And look at the gradient, mean gradient across the mitral valve here. At a heart rate of only around 100, his mean gradient increased to 18 and TR gradient also increased to 43. So this means that he had significant mitral disease. The mitral valve was not uh, well compliant, and because of this, there was significant increase in gradient on minimal exertion. So he warranted intervention. What do guidelines say about it? So if we are dealing with non-severe mitral stenosis, but the patient is asymptomatic, and if the valve area is between 1 to 1.5 centimeters square, if the gradient increases beyond 15 or PA pressure more than 60, then it definitely becomes a class 1 indication for intervention, and we may have to even go for surgery if the valve is not suitable for BMV. If the valve area at baseline is more than 1.5, but the gradient increases beyond 15, then it is a class 2B indication for BMV. In contrast, if the patient presents with severe MS and there are no symptoms, so if the valve area is less than 1 and the patient develops symptoms at low exercise threshold, it is a class 1 indication for intervention. Valve area 1 to 1.5, there are symptoms and the gradient and PA pressure increase significantly, again class 1 indication. And if a patient has valve area 1 to 1.5 centimeters square, the patient is pregnant or is undergoing some non-cardiac surgery, then development of symptoms and increase in gradients across the mitral valve and the tricuspid regurgitant gradient, then this is a class 1 indication for intervention prior to the non-cardiac surgery or during pregnancy if feasible. So I move to the next case here. So this was a 70-year-old gentleman, hypertension, no diabetes. He was incidentally detected to be having Clail P2 of PML with eccentric severe MR. His LVEF was normal, LV size was normal, LVGLS was minus 24%, which was very much normal. LA size was just 4.1 centimeter and PSP was normal. So echo-wise, everything was normal. Sinus rhythm, he denied any symptoms. So now here there was a dilemma that he was a 70-year-old gentleman. He had a valve lesion which was eminently repairable. And I was concerned whether if we delayed surgery, then with surgery, with increasing age, his surgical risk would increase. So was it wise to delay the surgery? So I decided to proceed with stress echo in this patient. As we can see here, these are TE images. At baseline assessment, PML is flail, there is eccentric severe MR, which is clearly appreciated here. So he exercised very well, 70 years age, 10 meds, no symptoms, no increase in peer pressure, and LVF also increased from 62% to 69%. There was good increase in LV contractility, and LVGLS also increased from almost 24% at baseline, it increased to 28%. So 4% increase, which is very much normal. For contractile result, we just want 2% increase in LVGLS. So obviously no intervention was performed and he's remained well for 2 years since his initial presentation. His latest echo, which was performed 2 weeks ago, didn't show much change in overall size of the left ventricle, LA, MR, PA pressure, although his LVGLS has decreased from minus 24% to minus 19%. Now, contractile reserve has been used for many years for assessing the condition of the left ventricle in patients with asymptomatic severe primary mitral regurgitation. This is one study, nearly 2 decades old, from Dr. Tom Marwick's groups. 71 patients with isolated severe, moderately severe to severe primary MR, NYHA class 1. Contractile reserve in this study was defined as at least 4% increase in LVEF. And the study showed that contractile reserve was one of the uh, only two independent predictors of post-operative LVEF in patients who underwent surgery or follow-up EF in patients who were managed medically, and it was also an independent predictor of event-free survival over a follow-up of 4 to 5 years. In a more recent study, uh, GLS was used along with LVF as a measure of contractile reserve. So GLS more than 2% increase was indicator of preserved contractile reserve. For EF, the criteria was same, 115 patients. So in this study, LVEF-based contractile reserve was not predictive of outcomes, but GLS-based contractile reserve assessment was clearly predictive of outcomes. The difference here was because of the patient population and various other reasons. The patient profile was different, and that's why the LVF-based contractile reserve was not predictive, because these were the patients who had presented early, relatively early during the course of their disease. They were well, not symptomatic. The MR was also moderate in many of these cases. And that's why GLS was able to predict contractile reserve, not LVF. But basically, both these studies show that assessment of LV contractile reserve can be helpful in deciding about the need for intervention in patients with primary MR, which is severe, but the patient is asymptomatic. Now, another example, 67-year-old gentleman, hypertension, diabetes, CAD. He underwent bypass surgery in 2020, normal LVEF. Then in October 23, he had PTC with stent to RCA. Then he again had some symptoms. A check angio was done in March 2024, which showed patent grafts and patent RCA stent. Now he presented again with class 2 to class 3 dyspnea. Vitals were normal, but he was obese with a body mass index of 32. So the question was, what was the reason for his dyspnea? Was it HFpEF? Was it coronary artery disease? Or was it some lung disease, especially because he was obese? So these are his stress echo images. There was no wall motion abnormality at rest or on exertion. He didn't have any ECG changes or chest pain, but had developed significant dyspnea at 7 days. When we look at the mitral inflow pattern, these are the baseline parameters: E velocity 77, medial E prime 7, lateral 10. So average E over E prime was 9, which is almost normal. After exercise, there was increase in E velocity, but E prime also increased, medial 9 and lateral 12. So the average E over E prime was around 12. So there was increase from 9 to 12, but it was not significant enough to justify the diagnosis of HFpEF. Now let us look at the right side parameters. So these are the baseline findings. RV S prime 7 centimeter per second. So it is reduced, indicative of RV systolic dysfunction. TAPSE was also reduced 12 millimeter. RV free wall strain was relatively okay. ER gradient was 22, so estimated PA pressure was 25. And I divided TAPSE by PASP to yield this ratio, which is a measure of RV pulmonary artery coupling. So the ratio was 0.8, and using strain, the ratio was 0.9. But after exercise, there was further reduction in TAPSE, 10 millimeter. Strain also decreased to 18%. PA pressure increased significantly to 45. RVS prime remained same. So there was worsening of RV systolic function, an increase in PA pressure, and the TAPSE PASP ratio also decreased significantly. RV strain to PSP ratio also decreased significantly. He also developed lung congestion, as we can see in the form of B lines here in this, which were not present at the baseline. So basically, he had some increase in LV filling pressure, significant increase in pulmonary artery pressure, significant worsening of RV systolic function, significant worsening of RV PA coupling, and lung congestion. So all these abnormalities have prognostic significance. Of these, RVPA coupling has gained a lot of interest in the recent studies. This is one of them, which showed that the patient who have TAPSE-PSP ratio less than 0.35 have significantly poor event-free survival when they are followed up. So in this patient, the ratio had decreased to 0.22, although that was on exercise. These are resting parameters. Now, here, this patient also developed lung congestion. The question is, what could be the mechanism of lung congestion? Was it because of increase in LV filling pressure? Because when we looked at the E over E prime, the rise was not that much. So interestingly, it's been seen that while LV increase in LV filling pressure leading to pulmonary venous hypertension can certainly cause pulmonary congestion, lung congestion can also occur just because of right side failure. Because as the right side failure occurs, there is increase in the central venous pressure, which reduces lymphatic drainage from the lungs and can lead to lung congestion. So in this patient, lung congestion could have been because of both the mechanisms. So just to summarize, through these three cases, stress echo is a powerful diagnostic modality capable of providing a lot of valuable hemodynamic information in a wide variety of cardiac and non-cardiac disorders. Significant diagnostic, prognostic, and therapeutic implications are derivable from the information that we get from stress echo. Thank you so much.
Thank you, Dr. Manish. As a part of this stress echo, we were told to include the diastolic stress echo. So I will be dealing in a very simple manner. Is it seen now?
Yeah.
So it will be a sort of very simple presentation. Now, why is the topic of diastolic dysfunction important? Because it is a key factor in pathogenesis of heart failure. And it accounts for about half of the heart failure hospitalizations. And the signs and symptoms are because of increased LV filling pressure, which is seen by the E oblique prime ratio, which will come to it just now, despite a normal ejection fraction. Sometimes these terminologies may be confusing. LV filling pressure refers to either a mean pulmonary capillary wedge pressure, mean LA pressure, mean LV diastolic pressure, or left ventricular end diastolic pressure. So they're almost the same. So, but some persons write different terminology, but they are almost the same. Now, one basic rule of a diastolic dysfunction is a relaxation abnormality is present in all grades, and this relaxation abnormality is shown by an early diastolic wave in the tissue Doppler, which is known as the E prime wave. So that means E prime waves indicates a relaxation abnormality and present in all grades of diastolic dysfunction. As the diastolic dysfunction increases, the ventricles become more stiff, and this leads to an increase in the mean LA pressure. And because of the mean LA pressure, there's increase in mitral E wave velocity, because that depends upon the pressure in the left atrium. At the same time, as we know that E dash always decreases because of a diastolic abnormality. So E increases, E dash decreases, so E oblique E prime increases. So this is the basis of the breathlessness or the filling pressure. This is the reason. And because most of the filling occurs in early diastolic E wave, less filling occurs in the late diastolic phase, so the EA pressure is increased. So that is the basic rule is that mitral E increases, annulus E dash increases because of relaxation abnormality, E oblique E prime increases, and the same thing. Now, whether it is the ASC guidelines, you can see a diastolic stress echo indicated. Whether it is ESC, again, you see at some stage they write a stress echo. And if you see the algorithm at Mayo Clinic, again, they write a diastolic exercise in certain great patients also. So that means it does include some important features also. That way, I think all guidelines. Now, whenever a patient develops an exertional dyspnea, one of the causes is that exercise-induced diastolic dysfunction besides all the others also. It was actually in one of the studies it was shown that two largest categories of an unexplained exertional dyspnea were a diastolic dysfunction and a pulmonary artery hypertension, and this was present in almost about 30% of the patient. So that means this exertional dyspnea continues to be a very important feature. So now we come to the basic, these four things to be seen, why there is a need for a diastolic stat echo. In many asymptomatic patients and about 1/3 patients of a heart failure with preserved ejection fraction have a normal filling pressure at rest. So exercise echo could unmask the diastolic abnormalities which were not present at rest, as a result of which the LV filling pressure, which was normal at rest, increases during exercise because of tachycardia and the decreased diastolic filling time. And it is one important test to differentiate if the dyspnea is of a cardiac or a non-cardiac origin. So these are some of the three important points why this diastolic stress echo is indicated. Now, what is the principle and indications of stress echo? Now, this is taken from a JAC. Now, this you say there are two groups of patients. One is A and one is B. Now, both of them have got almost a normal pulmonary capillary wedge pressure. But a person who is a normal patient, when he exercises, he increases his cardiac output without a significant decrease in pulmonary capillary wedge pressure. So this person is a normal one, which doesn't involve any other increase. While this patient with a diastolic abnormality or a myocardial disorder, the increase in cardiac index is less, but at the cost of a much increased pulmonary capillary wedge pressure. So this patient continues to have a normal pulmonary capillary wedge pressure, and this patient continues to have a marked increase in the pulmonary capillary wedge pressure without any significant increase because of a diastolic dysfunction. So in a normal individual, you can see when you exercise, the E velocity increases, the E prime velocity increases because of a good relaxation, and the E oblique E almost remain the same. But if there is a non-compliant LV or a diseased person, the E increases because of an increased mean LA pressure. The E prime remains the same because the diastolic abnormality is present, and so E oblique E prime increases in velocities. So this is the basic of a diastolic stress. But there may be some gray zones that some patient has a question, exertional dyspnea. Now here you see at rest the E oblique E prime is about 8. Now, but after exercise also, it also remains at 8 because the mitral E increases, the E dash increases, and the E oblique E prime remains the same. So there is a good myocardial relaxation and a normal diastolic function. This is a normal response. However, here, a known CAD, diabetic hypertension, complaints of dyspnea, and more significant. Now here you see the at rest, the E oblique E prime is at about 6. But as the patient exercises, there is more increase in the E wave because of mean increased pressure, but E dash remains the same. So the mitral increases, annulus E dash remains less or same, so E oblique E prime increases. From 6, it goes up to 14:1, indicative of a diastolic heart failure. So these are the basics also. And some of the current indications are when a resting echo does not explain symptoms of dyspnea, either a rest or an exertion. Because most of the tests are done at rest also. And grade 1 dysfunction with symptoms and the normal mean pressure. Now, grade 1 dysfunction is many times ignored, thinking that it is one of the usual presentation of the elder age, but when it is associated with symptoms, then it's a precursor to overt heart failure. So that is one of the cases it should be done as a diastolic stress echo. Indeterminate cases with borderline E oblique E prime ratio. So when there is a borderline with some vague symptoms, it is indicated. Two groups of patients usually do not require a stress echo. One is patients with normal heart and normal diastolic functions with no symptoms, or patients with abnormal diastolic function and rest consistent with increased filling pressure. So once the diagnosis is always clear, it may not be indicated. What is the methodology? Now, it can be the invasive, but a non-invasive is more practical and clinically applicable, because this already is a good gold standard, but it cannot be done almost in every patient because they do a simultaneous echo and studies both at rest and exercise. And there is no universally accepted protocol. In European countries, they mostly prefer a supine bicycle. In other countries, including our country, we provided a treadmill, and it is believed that the yield for a positive study for dyspnea is doubled. And sometimes a passive leg lifting is done, in which the patient who cannot exercise, you lift the leg to about 45 to 60 degrees, and about 200 to 300 ml of blood goes to the heart, increase the preload. And so that sometimes it is being used. And what we recalled at baseline, a mitral E velocity, A velocity, so mitral E and A. So that is mitral wall. Tissue Doppler E velocity, so that we get an E oblique E prime ratio. Then the PA pressure, which also gains an important. So because we don't want to waste time, we always see which scan plane has given the maximum TR jet velocity, and we mark the transducer location, so that after exercise we don't have to search from where we found a PA pressure. So normally it is done because when you exercise, the mitral E and A waves fuse because of tachycardia. So we cannot do a Doppler study. So that is utilized for seeing any wall motion abnormality. You see for about 1.5 to 2 minutes as any wall motion abnormality, and usually after 2 minutes, when the heart rate falls below about 100 to 110, then the Doppler studies are done, because at that time the various studies, the slows get stable, and moreover the raised filling pressure persists for about 4 to 8 minutes. So you can see both for wall motion abnormality and also for this. So it becomes a combination ideal for evaluation of dyspnea once you are seeing all the wall motion plus the Doppler. For example, this patient you see after exercise, automatically you see there is a marked akinesia of the interventricular septum LAT territory, and at that time you see the E oblique A ratio comes to about 2 more than 2 with a marked decrease in deceleration time, and after a few minutes you're all neutral or normalizes. So just give a time to see for both of these things. So now we have seen this. What is the criteria for positivity? Any symptoms or exercise capacity? Then as I said, E or E prime ratio, which is the main thing to see for any LV filling pressure, both immediately and at the recovery time, and the TR jet velocity, which increases the specificity, because in a normal patient, when the patient exercises, the gradient remains below 43 of in a TR jet gradient, but when it is more than 3.4 meters per second, it increases the specificity. A dobutamine stress test is usually not recommended because it is a vasodilator and may decrease LV filling pressure, and is not physiological for dyspnea, which we cannot see, and it augments lucitropy. As a result of it, the diastolic functions cannot be assessed. Now, one interesting study has come out very recently in a JAC, in which the authors worked. They took 215 patients with a supine bicycle exercise at a low exercise, that is 20 watts, and about 45 invasive studies were done. Interestingly, they combining both of them, they found that abnormal increases in pulmonary capillary wedge pressure occurs mostly in a low level exercise. Beyond that, there was a minimal exercise of exercise. For example, at this, the minimal increase at the peak exercise is much less, but the maximum exercise at the low level exercise. And then they found that the predicted E and E prime ratio of less than 50 with a cutoff value of 12.4. So they said 12.4 is a cutoff value. Below this, that means the patient has got no increase in E of E prime. And if it is more than 12.4, that indicates that the patient has got most of a diastolic dysfunction heart failure, that it was found to be high specificity and positive predictive value, and this was also confirmed in various studies. So they felt that a low-level exercise at 20 watt is almost equivalent to the usual daily activities where dyspnea occurred. So then with this study, although it is single center, which requires more study, can it replace the costly stress test? Or we come down to the 50, 60 years back, what we used to do a double master test. But this is an eye-opener thing which needs a further study. The emerging parameters are few. One is an LA strain. And you know the LA modulates the LV filling by three functions. One is the reservoir function, which when the left ventricle is in systole, the LA is in diastole, and when it is in filled up from the pulmonary vein, there's the increased volume. This is reservoir function systolic, and in the diastole, like a normal Doppler, you see a mitral, there is a conduit function and the LA volume, that is a contrite function, that when you do a late diastole to augment the factors. And a positive strain, these are all things that this has been shown that they are at the reservoir strain, it is inversely proportional to the filling pressure. As the filling pressure goes on increasing, or the diastolic dysfunction goes on feeling bad, the reservoir function comes down. So this was a study. This is how you see. So this is the positive strain because of this, because of the expansion of the LA. This is the peak atrial systolic velocity, and these are some of the others, and they are very much related to the filling pressure. And this was shown by one slide by Dr. Nitin Burkle. He took three group of patients. One was a grade 1, grade 2, grade 3, and he showed that as the diastolic dysfunction grade goes on increasing, this goes on decreasing. So that just seeing a reservoir strain, you can also judge what is the filling pressure. And why this occurs is that because of an increased LV filling pressure, there is an increased LA pressure with the stressed LA. When there is an increased LA pressure, the gradient between the pulmonary vein and the LA is decreased. So less blood goes into the LA at that time to the reservoir function because of increased LA pressure, and so that there is a difference between the pulmonary vein and filling. So that is why it is reduced, and it is well validated against invasively determined filling pressure, and reservoir strain is also identifies patients with intermediate scores and in which there is the increased LV filling pressure. So this is sort of a good study. And this was shown by by Lisa Thomas, that they did in various types of filling pressures, and they found they gave a figure of 18%, that when it is more than 15%, 18%, it usually indicates a normal filling pressure, but when it is less than 18%, it indicates a the opposite also, it is an elevated filling pressure. This was also shown in one of the studies that a left atrial reservoir strain of less than 18% and a pump strain of less than 8% indicates an increased filling pressure. So they found both the LA strain and the reservoir strain, both of them can be correlated with the filling pressure. And this is one of the ESC criteria, that once you do a stress score in these cases, if the E/E prime goes more than 15, TR velocity goes more than 3.4 meters per second, then the criteria is fulfilled and no further test required. The patient has got a very high filling pressure. But if it is not fulfilled and your diagnosis is not being reflected, so then you have to go for a right heart catheterization. They say that if an invasive one, if your LV filling at EDP is more than 16, pulmonary capillary wedge pressure is more than 15, it indicates that there is a diastolic heart failure. There is nothing to be done. But if it is not there, then an echo stress is done at this time. So that is during hemodialysis. And once the PSCP is more than 25, it indicates a heart failure present affection. But majority of the studies are usually done at this level with the addition of the more factors like an LA strain and various other factors. Some technical challenges, tachycardia, low-level exercise leading to 10% failure, exercise-induced arrhythmias, chronotropic incompetence, and failure to get a good TR jet velocity is about 50% of cases. So the take-home message is, it is a well-established but less utilized technique to assess cardiac dyspnea. It should be utilized more, as we have mentioned now, and the accuracy of resting Doppler is doubtful, then we do it. It confirms or refutes the diagnosis of heart failure, and do not ignore symptoms of exertional dyspnea in a group of patients with grade 1 diastolic dysfunction. More work is needed to refine and standardize the methodology and other parameters and how much exercise to do. And LS trade is a big step forward in it. Thank you very much. Now, any questions you can take?
Thank you very much, Satish, for this excellent overview. Yeah, so I think we are a bit over time, but that's all right, I think. So let's take some questions, right, from the chat box.
Some questions have been posted here. So one is that at peak dobutamine dose, for how long should we wait before acquiring the images? This is a technical aspect that once you have achieved the peak dose and the heart rate is above 85% of maximum predicted rate, should we wait for 30 seconds or 1 minute and then take images, or immediately you can acquire the images?
Okay, I will answer that, but the others can chip in, Manish, Nitin, and Satish, if you want to. So when we go to the peak dose of dobutamine, we should take it at peak dose of dobutamine. We don't need to wait any longer because the endpoint has been reached. So you just get the images as quickly as you can. And also the advantage of dobutamine, of course, is you can also look at perfusion very nicely because the patient is lying, the intravenous lines are there. You give the contrast, through infusion. So you get both wall motion and perfusion data. Yeah, I would do it as soon as we finish, as soon as we reach the peak.
Next question.
Your comment about operator expertise in stress echo for CAD assessment and difficult decision making.
Okay, Nitin, would you like to take that?
Yeah, true. I think the stress echo, especially the treadmill stress echo, needs very quick imaging. Okay, so you have to develop a dexterity to take all the peak images within 90 seconds. Okay, so that is very important, and a very good training of your subordinates to take the patient to give the contrast at peak and take the patient back to the bedside, and a real mock practice before starting is also very important. Then I think should do at least 100 stress echoes with a mentor to develop that eye for details of regional wall motion abnormality. And then again, the very basic training, like look at one segment at a time, look for the systolic thickening rather than the motion. Look at the LV cavity, non-dilatation or dilatation, okay, at peak exercise. I mean, non-reduction in the LV cavity size at peak exercise. All these things you should point out. So I think there is definitely a lot of training required, but very easy to get it because these are regular patients, and it's very easy to do without any discomfort to the patient.
Nitin, any advice for those who do not have a myocardial contrast echo facilities?
Yeah, actually,
Uh,
I think
if
Uh-huh.
after if what are the number of segments if they're not visualized, then they should not do a stress echo, or what is your advice?
As per the guidelines, if the 2 consecutive segments are not seen, then probably you will miss one perfusion territory. So if you have got two consecutive segments where the endocardium is not well delineated, it is better to shift to the LV opacification contrast. See, probably the perfusion needs much higher levels of skill and instrumentation, but LV opacification is very easy to achieve for almost everyone. Okay, and it is quite cheap also now, and generally you use multi-dose vials, so you can divide the cost between different patients, and I think it doesn't add much to the cost of the stress echo. It just needs that you should have the person to put the IV line and give the contrast. That's all. And so I think everyone should strive to use LV opacification contrast, because many times even from the rest images you will never know how good or bad your peak stress images would be. So I think it is safer to use the LV opacification contrast. Now, if you don't have, then at least you should be doing the stress echo on a high-end machine where the endocardial delineation is very good. And if you don't have a good endocardial delineation, then better not to do the stress echo.
Next question.
Next question is, any role of passive leg raising to increase the flow reserve? I think, Parashar sir, you've already covered this, but you can.
Yeah. I think Roxy can tell something. But he has done a double stress echo even in 88, 84, 88%. So Roxy, in your practice, how often you do a raised leg test?
Well, okay, so here we are talking about raising to increase the flow, not for stress. I mean, you can raise. You can look at, for example, diastolic. For example, in case of diastolic heart failure, etc., you can do that, right? Because all you want to know is the stiffness of the left ventricle.
Yeah.
Right. So that's a good adjunct to do it if you want to do it.
Yeah, because because as per literature, within 1 minute you can get the changes of the increased preload also, because they transfer about 200, 300 ml of fluid immediately. So within 1 minute you can get some positive results.
Yes. So it is useful. But in our practice, when the patients first come in with as a diagnosis of shortness of breath, and we are not clear what is that due to, because we combine looking at both wall motion abnormality and diastolic dysfunction, we tend to do the normal stress echo with bike, because we want to also exclude coronary disease in this patient.
So next question in the chat box is for Dr. Nitin. The question is whether false positive stress echo may be due to microvascular dysfunction in case of absence of obstructive coronary artery disease.
Yeah. Actually, false positive echoes you would get in different forms. One, as I showed you the case where there was actual LV dilatation and A kinase, which was very much visible. But there are other subtle ones, like you expect at peak exercise, especially in the upright exercise, that the LV cavity size has to decrease at peak exercise. So non-reduction of LV end systolic volume itself is also a positive stress. And secondly, the no increment in the ejection fraction at peak stress is also is actually an abnormal test. Now, all these may not be really associated with an obstructive coronary artery disease, but there are various causes for that, and one of is a microvascular dysfunction, but it's not the only cause for false positive stress echoes. As we know that we may be unmasking a cardiomyopathy. Okay, that cardiomyopathic process may be reduction in the inotropy of the myocytes and also interstitial fibrosis and so on and so forth. So it's not the only, so microvascular dysfunction is not the only cause of it. Okay, so you can have the unmasking of cardiomyopathy as one, or secondly, at peak dobutamine, you can have a Takotsubo kind of a apical ballooning also, which is also very well described, which we have seen especially in the cirrhotic patients. So that is also another one, another cause for a positive stress echo, or getting a dynamic LVOT obstruction can also cause a false positive LV apical ballooning. So, but one thing is that false positive stress echo is not a benign condition that one should realize.
You told in your talk also, but actually it's a common phenomena that you get false positive DSC, because it happens that in a center where a lot of surgeries are happening, like ours is a very busy ortho center, and patient is on a stretcher and you get a DSC positive, then you wheel him to the cath lab and then you find that the coronaries are normal, it becomes embarrassing for the non-invasive person to actually, defend themselves.
There's nothing to be embarrassed about, because you have unmasked an endothelial dysfunction in this patient, okay, and that has definitely has a prognostic value for sure.
Yeah, I think what should be made clear to your colleagues is that, now the term false positive is no longer used. Now it's called mismatch between regional wall motion abnormality or abnormalities in echo and CAT data. It's a mismatch. So, and as Nitin has pointed out, that could be due to several other reasons. And we know that with good going LV dysfunction or regional wall motion abnormality, there is something wrong with the LV. There's no question, right? So this patient needs to be further investigated rather than tell you that you've got it wrong. I don't think
So glad I
that
think there is
shouldn't be
a
the fallback position.
comment on that. Yeah.
Yes.
Actually,
In fact, you
one
should tell
clarif
them. You should
one
tell them
clarif
off.
one clarification from Roxy and Nitil. Many workers say that when you're already doing any stress echo, why don't you routinely combine a diastolic with it also?
Yeah,
So
that
you're already doing it.
exactly. I think that is what the ABCDE, as proposed by Dr. Roxy and the other European group. I think that is exactly what it is doing, because they are looking at the dyssynergy, but or asynergy, and also they are getting the hemodynamic data, including even the lung congestion with
Yeah.
it. And also they are looking at the something like a end systolic pressure volume relation, like they are taking the systolic BP divided by end systolic volume. It is just a surrogate of an end systolic pressure volume relationship. So they are looking at the LV hemodynamics also, and also looking at the ischemic part in the same ABCD. And if it goes beyond E, then of course other valvular diseases and PA pressure increment. So I think stress echo has got tremendous potentials, which I think we are just scratching the surface of it by just looking at the regional wall. If we take the hemodynamic data into it, we are much uh, uh, we are much better aware of the correlation of the patient's symptom and the actual dynamics, whether it is cardiac or non-cardiac. And more than that, now we should know that the heart failure incidence in the community is increasing, and probably we are picking up those by early stress echo hemodynamic.
Simi, any other question?
Also, just wanted to add one point. This LV filling pressure assessment and PA pressure and MR. This is what we routinely do during any stress echo for CAD assessment also, because not only these parameters are helpful for diagnosing HFpEF, but they are marker of CAD also. If there is ischemia, MR worsens, filling pressures go up, PA pressure increases. So that increases our confidence also in the severity of the disease, coronary disease that we have unmasked.
Yeah.
So I think it's already a part of routine stress echo, every stress echo test.
Adding these two things is very important. Is that the same probe just look at the lung in the
Yes.
in the first and second intercostal space in the anterior axial line for the B lines, and generally on your echo machine there will be a carotid probe. So just at the end of the test, just look at both the carotids, or at the beginning of the test, both are the carotids, and that gives an immense information which has got a
Mm.
therapeutic implication also.
Yeah. So
Any role of combining GLS during exercise?
the problem with GLS, of course, is if you look at the data for stress echo, it's very sparse. It's not very, we don't have very large populations being investigated. It is feasible, you must allow the heart rate to come down, but not a lot, to get the optimum GLS data. But there is a lot of variability during exercise with GLS data. So that's why there are not large studies, and of course, very little prognostic data with GLS.
Yeah, I'll add to that, because at the high heart rate, I think the speckle tracking may not be accurate at
Yes.
all. Yeah, because your frame rates are limited and your heart rate is very fast, and there is a lot of translational motion of the heart across the imaging plane. So I don't know if the peak GLS data will be really reliable. But I think more than that is to look at the ischemic memory, which actually can help, because the patient before the test every valve can actually work as its own control. And you can also do it at 4 to 5 minutes after the peak stress, when the patient's respiration has normalized and the heart rate has come down, and you've got a lot of time to take the images, good quality images, and look at the strain dispersion. Of course, that will have lots of false positives also, but I think the sensitivity is really good, and especially borderline cases, it can really help.
One last question is there regarding aortic stenosis, Dr. Roxy. It's commonly we encounter cases where the aortic valve is thickened, hardly opening, and mean PG of 10 to 15 millimeters of mercury only, despite normal ejection fraction. What to do in such cases? Very unlikely that the gradient will increase to 35 or 40 millimeters of mercury, even with the dobutamine.
So can you repeat that again?
If the aortic valve is thickened, hardly
Yes.
opening, mean
Yes.
gradient is 10 to 15,
Mhm.
despite normal ejection fraction. What to do in such cases? Because very unlikely that the gradient will increase to 35, 40, even with dobutamine.
Yeah, so I mean, you have to take each case, into consideration. So, a normal ejection fraction doesn't mean that the patient has a normal flow, right? So the patient can still have low flow, and the valve may not open because just the flow is low. Now, in some cases, the scenario that you're really talking about are elderly patients who has got other, afterload, increased afterload because of other reasons like hypertension or even vascular disease, etc. That itself can reduce the flow and everything, the flow and the gradient. In fact, the flow is not only dependent on gradient, but it's also dependent on afterload. So when you say it's unlikely that it can go up from 15 to 40,
That it can go.
right? It doesn't need to go up to 40. That's what I was trying to imply. That all you need to do is to get your flow rate up to a normal level, and then see what the gradient is and what the aortic valve area is looking like. So more importantly, what the aortic valve area is looking like. Because if the aortic valve area doesn't open, even after increasing your flow to over 210 or so, then it is highly likely to be severe aortic stenosis, not very severe aortic stenosis, but severe aortic stenosis that will benefit from intervention. That's what we've shown.
I think what he meant was a mismatch between 2D echo and a Doppler.
Yes. So with 2D echo, you're saying that the aortic valve is not opening.
Severely
And very thickened.
I
Yeah.
think, yeah, it's a very important point that we should not be aiming for increasing the gradient to 35, 40, which is the cutoff for severe AS. And if the valve area is not increasing to 1 or more than 1, even at a flow rate of 210, then that means it is a severe AS. So this is
Yeah.
what Professor Senior is saying. Yeah, valid points.
Rest all questions are repetitions, so I think we can close our meeting.
Okay. Thank you very much for giving us such a big knowledge to all of us. And I hope we'll involve you with our annual or any monthly webinars also. So Roxy and Nitin, thank you very much. Manish is a part of our webinar teams. I've not thanked him and neither Simmi, but both of you should be bothering you quite a bit for many other things also. So thank you very much. Thank you.
Thank you. Thank you.
Thank you.
Thank you, Dr. Nitin. Bye-bye.
Okay. Bye.